Thank you very much, Larry. As you all know, insulin has now been on the market for almost 100 years. It's efficacious, but it's often correlated with hypoglycemia and body weight increase. And it's actually often used in patients who are dysregulated with high HbA1c because people think that we can just as good start insulin right away. But as you also know and have seen here and all over the conference, we've had a lot of new classes for the treatment of type 2 diabetes. So we, in this trial, actually are, to our best knowledge, the first to compare an injectable insulin with a combination therapy with dapagliflozin, SGLT2 inhibitor, and saxagliptin, a DPP4 inhibitor. What we did was that we took patients with type 2 diabetes who were dysregulated, having an HbA1c between 8 and 12, so pretty high in percent. They were supposed to have a BMI below 45, and then they were, actually we showed the 24 weeks data as an oral presentation at the ADA, but here I show you the full 1 year data. What we did was that after a short run-in period where we actually had CGM on the patients, they were randomized to receive either combination therapy with dapagliflozin and saxa, and then or in an open label manner because they had to take injection to insulin glargine. Patients were treated with insulin glargine as we usually do through the SPC. They were started at least 10 units or 0.2 units per kilo per day. So being a 100 kilo individual, they would be started at 20 units. Then they were titrated every third day if FPG was above 5.5 with 2 units. Only in the first 8 weeks, and then we actually kept the insulin dose throughout the trial. They ended up at approximately 37 units, of course with huge variation from one patient to another. Our primary endpoint was to look at HbA1c, and we actually wanted to see it as a non-inferiority trial, but we did of course also look at body weight and hypoglycemia. In the table here you can see the patients were middle-aged. They had actually had diabetes for a long time, approximately 10 years. Their HbA1c, it was supposed to be between 8 and 12, and the average was 9%. They were obese. They actually had a BMI of approximately 32, and they had a FPG just above 10 millimolar or 190 milligrams per deciliter. Their background therapy had to be metformin and with or without sulfonylurea. And down here in figure 3 you see the major or the primary endpoint, which was HbA1c reduction after 24 weeks, which was presented at the ADA and is now hopefully under or in press soon. We had non-inferiority. After 52 weeks you can see dapagliflozin and saxa was actually slightly lower than the insulin treatment. In respect to body weight, as I said, and as you all know, usually with 1% improvement in HbA1c, you get a 2 to 4 kilo body weight increase with insulin. And what we actually saw in this trial was after 24 weeks, we had a difference of 3.6 kilos. And I really like the figure here because you can see that the two curves on insulin and dapasaxa actually did drift apart. So at the end of 52 weeks, it was a difference of 4.6 kilos. Down here you see the number of patients reaching HbA1c below 7 without hypoglycemia, which surprisingly not was in favor of dapasaxa. And down here you can see patients requiring rescue or discontinuation due to lack of glycemic control was actually not significant in the group, but tended to be low on dapasaxa. In respect to adverse events, there were approximately 65% in the dapasaxa and 68% in the insulin. Not any surprises, and actually what we found was that with hypoglycemia, which was the major difference, was 31% with dapasaxa, and you might say, why did they have hypoglycemia? But that was of course because quite a few of them had a backbone of issue. And with the insulin treatment patients, we had actually almost 50% of the patients having hypoglycemia, and 3 of the patients treated with insulin actually had a severe event. So the conclusion from this trial was that dapagliflozin treatment numerically improved glycemic control and reduced body weight from baseline compared to insulin. And we had a greater proportion of patients reaching target. They did not go to normal glycemia. They were really high from where they came from, but it was a good and efficacious treatment. And remember that it was tablets compared to injections.